All right. Good morning, everybody. Today we will have a very important topic to cover. So we'll talk today about the ureter and urinary bladder. So what would be our learning objectives for today? We'll have two organs to deal with. First of all, we will talk about the anatomy of the ureter. So we'll talk about the ureter itself. And clinical application to know that will be the renal colic. And second organ which we will focus on, that will be urinary bladder or simply bladder. We'll talk about a few clinical applications to know. Cystocele, we'll talk about the cystoscopy, micturition reflex, and paracentesis of the urinary bladder. Right, so let's start with the ureters. That is the male renal system shown over here, right? Urinary system. What is it? Tell me. Kidney, right? Which one it is? That is a... So right or left? Okay, let me navigate a little bit. First of all, once we have the anterior view, like you're looking on the cadaver, for example, or you're looking on this image, which is on front of you, right? Anterior view. So you're basically looking on your patient. Whatever is your right hand will be patient's side, which one? Left side. Whereas your left hand will be patient's right side. The same thing we can say about the medical images, like for example CT scan or MRI. Whereas your right hand will be patient's what? Left side. Whereas your left hand will be patient's right side. So again, one more time, which kidney is that? That is the right kidney. And that is my right hand, so that will be left kidney. Because that is the anterior view. We are looking on the structures which are on front of us. Okay, now from the kidney, how do we call this long tube to bring urine down? How do we call it? Ureter. How many kidneys do we have? Two. How many ureters do we have? Two. Now ureters will bring urine to this organ, bladder. Now could you tell me the ureter will bring urine when? At the morning, at the daytime, at night time. Another way to ask you, when the urine will be secreted by kidneys? 24/7, all the time, constantly. So secretion of the urine happen constantly. The ureter will bring the urine to the bladder constantly. That's why we need the bladder. What is the function of the bladder? Tell me. To store the urine, because it constantly secreted, but we go into the restroom periodically. In between, the urine is stored in the bladder. Are we good?
Yes.
Right. Now, from the bladder, we have the canal to release urine out of the body. How do we call this canal? Ureter. How many ureters do we have? Just one. We have one bladder, one ureter. But we have two ureters and we have two kidneys. Are we good?
Yes.
Right. Now let's talk about the ureter specifically. That is a long tube. What is the average length of the ureter? 25 to 30 centimeters. So it's really long. It's sitting on the posterior abdominal wall. You had already a lecture about the posterior abdominal wall, so you are familiar with, right? So let me again navigate a little bit. Can you see my pointer? This is better, right?
Yes.
Maybe the colors should be different. Okay, anyway, so what is this? Which one? Right kidney. And that will be left kidney. And why is that? Well, first of all, that is anterior view. You are looking on your future patient. That's my right hand, so that will be left kidney. That's my left hand, so that will be right kidney. Also, to prove it, you can see the structure over here. What it is? Left renal vein. Left renal vein is a long horizontal vein which starts from this one, which we call inferior vena cava, IVC, and it crosses the huge artery on front. How do we call this artery? Aorta, right? And the matter of fact, this above of this, that will be right, superior mesenteric artery. Very good. Now, that's what we call the hilum of the kidney, right? We have the three components over here. What do we have? Renal vein, renal artery, and ureter. Now, that is ureter. Which one? Right ureter. That is the left ureter. Now, keep in mind that in the OSPE you will be presented with the specimens of the posterior abdominal wall, pretty close, like this photo, right? So, in order to answer those questions, you also have to include the side. It's not good enough to say that as a ureter, which is good, but it gives you just the half of the point. The second half, you have to specify, is it left or right, if you're talking about the pair structures. Are we good? Which means you understand. Okay, now ureter runs down, and that is abdominal portion of the ureter on front of this huge muscle. Can you see this muscle over here? Psoas major muscle. Extremely important key landmark for us. And we will talk later on, we will have lecture about the cross sections, we'll have lectures about the CT scans, like medical images. So ureter will looks like the white dot on front of the huge muscle, which is the psoas major muscle. And why ureter will be white dot on the CT scan? Because of the urine. The fluid, urine will be white on the CT. So white dot on the front of the muscle, that will be ureter over here. Now ureter runs down and will cross the entrance into the pelvis. We call this pelvic inlet. And this specific border we call pelvic brim. So pelvic brim, right? Now you can see, maybe not clearly, but aorta bifurcates. Can you see the bifurcation of the aorta? Yes. What level is that? Very good. And what would be two terminal branches? Two common iliac arteries. Very good. Now each common iliac artery bifurcates again on the level of the sacroiliac joint. So we have, what do we have? External iliac and internal iliac arteries. So that's exact location of the ureter. So ureter cross the place of the bifurcation of the common iliac artery. Are we good? So later on ureter will enter the pelvic cavity and will join with the bladder. That is urinary bladder, the most anterior structure in the pelvis. Are we good? Now what is this? Little bit ahead of the time, that's how uterus looks like. That is a female body, and that is the uterus. Now, why it is not the prostate? Because you could not see prostate. Prostate is sitting underneath of the bladder. So it's below the bladder. The bladder will cover, that's a superior view, so the bladder will cover the prostate. So in the female body, between the rectum, that is the rectum, and the bladder, we have uterus. In the male body, we don't have it. So the bladder will be related to the rectus, behind the rectum. Okay, moving forward, the bony structures, the bony pelvis, he will be presented with these specimens, the bone specimens in the lab. So how many bones do we have in the bony pelvis? Okay, the correct answer will be 4. So we have two, how do we call those bones?
Iliacs.
No, iliacs it's a part. We have ilius, we have pubic and ischial bones. Collectively, they join together in the acetabulum and we call this pelvic bone. So we do have, or hip bone, we have two pelvic bones or hip bones. We have what it is?
Sacrum.
Sacrum in between, and those three collectively we constitute the bony pelvis. And the fourth one, it's a little bit over here. What is this? Coccyx, right? You know, like you will have pretty soon lectures of embryology with Dr. Paul, and he will tell you that you and me and everybody in this classroom at the specific point of the embryonic development had a tail. So that's what is left. So 3 to 5 tiny teeny vertebrae which join together, we call this coccyx, right? All right. Anyway, long story short, this line over here, which is the pelvic inlet entrance to the bony pelvis, we call linea terminalis, right? And here we have this ureter. When it crosses, we call this pelvic brim. Are we good? Right. Now, also in this block, you will be presented with the multiple medical images. And that is the first one to talk about. What is this? How do we call these images when we... Right. So that is the X-ray of the pelvis. So the structures which you should be able to recognize, they are already labeled. Like, for example, B, what it is? Pubic symphysis, that is the joint in between the two pubic bones. Now this D over here, what it is? Sacroiliac joint. Sacroiliac joint, it is a synovial joint, but normally there are no any movements in those joints. Why? Because we have very, very strong ligaments, which prevents normally any movements. In fact, if the movements will be there, the patient will have pain during the walking and instability of the gait. Okay, the C, that will be the ischial spine. That is the one, and we will talk later on why it is important. We'll talk about the blocks, neural blocks, and ischial tuberosity. The matter of fact, you all use the ischial tuberosity a lot. I would say too much. Right, because you are all sitting on it, and me are also sitting over here on the ischial tuberosity. That's where it is, right? Are we good? So everybody should be able to recognize the structures on the image like that. Now, could you tell me which side it is? Like, for example, one more. This one foramen, the huge over here. How do we call it? Obturator foramen. Let's guess which nerve passes through the obturator nerve. Very good. Now, if, for example, this A, I will put it here and ask, which foramen is that? You will answer obturator foramen, right? But right or left, could you answer which it is?
Right.
Okay, you could not answer this without the label. You know, like we have R or L on the X-ray films. If we do have, we can say exactly which side it is. If we don't, the film could be flipped over, so you would not know which side it is. So we don't ask those questions if there is no labeling. But if you will have, like, for example, L sitting somewhere over here, you definitely should say that is the right obturator foramen. Are we good? Okay. Now, speaking about the relationships of the ureter and overlying structures, later on you will have, yes? Three parts of the pelvic bone: ilium, ischium, and pubic. Three bones joined together to make the one. In adults, in the newborns, we have the separate one with the cartilage in the place of the acetabulum. Okay? But also you will have this topic in the lab, so I don't have any problem with that. Now, speaking about the ureter and relationship, you know that in male and in the female body, we have the different genital organs, right? Including the pelvic organs, pelvic viscera. And you will talk about them in details in the reproductive block next semester. But now we have to mention it anyway. So, what do we have in the male body? This on the top, which body is that? Male or female? Male body. So that's anterolateral view. We have a bladder. Now, what it is? Ureter. So we have two, left and right ureters. And we do have the structure what we call vas deferens or ductus deferens. That is the one which will bring semen, spermatozoa from the testis. Testis, they are in the scrotum, outside of the body, right? Outside of the cavity of the body. So inside of this vas deferens, they will travel and they will join with the seminal vesicles, which will secrete the fluid, seminal fluid. and together they will do the ejaculatory duct inside of the prostate gland. The bottom line is, you can see that the vas deferens crosses ureter on the top and make a loop. Or we can say ureter is located underneath of the vas deferens on its way to the bladder. Are we good? What do we have behind? Which organ is sitting behind of the bladder and those two are located? No, prostate is here. That's the prostate. Rectum. Behind of the bladder in the male body we have rectum. Okay? Now, which body is here? That is the female body. Let me navigate you a little bit. So first of all, that is superior view, and that is view from behind. That is a super or posterior view. So what we can see, that is a colon sigmoid running down into the rectum. That is a uterus, okay? And this thing on front of the uterus, that would be the bladder. Are we good? Now, this big tube over here, which is shown yellow, that is what it is. Ureter, on the way to the bladder. And that is, which is the red one, number 2, that is the artery to supply uterus. How do we call arteries to supply the uterus? Yeah, uterine artery. It does make sense, right? So uterine artery. And what you would say about their relationships? The uterine artery is sitting right above of the ureter. Very close, side by side. Why it is important? That has a clinical significance. In the male body, it doesn't have the clinical significance, but in the female, it is huge. Why? Because sometimes we have to remove the uterus. How do we call the surgery to remove the uterus? We call it hyster, which is the Greek name of the uterus. Ectomia means removal. So hysterectomy, removing of the uterus, it could happen to many reasons. It's not my job to discuss this today. But if we have to remove the uterus, first thing first, before you remove something, what you need to do? I mean, like some organ from the body. Ligate the artery, right? Because if you don't do this, what happened? Bleeding happened from the artery and the patient could die. So first you ligate the artery, like for example appendectomy, anything you remove. You have to first cut off the blood supply and after that remove the organ, right? So hysterectomy, the first thing first, we have to ligate the uterine artery. In many cases, the uterine artery has been ligated along with the ureter because they are sitting very close to each other. Okay, so the surgery has been done, and what happened after that? If you ligate the ureter, could you tell me, will it affect the patient after surgery? If you close ureter down, what happened? Yeah, the urine flow from the kidney will be interrupted. The urine will stay in the kidney. Kidney will still secrete the urine, and it will build up in the renal pelvis. It will create a huge, unbearable pain. Like on the scale 1 to 10, it will be like 9, or maybe even 10. It's huge. We call this renal colic. But before, let you ask this question. 59 years old woman comes to the local hospital for the uterine cancer surgery. As the uterine artery passes from the internal iliac artery to the uterus, it crosses superior to which of the following structures, which sometimes mistakenly ligated during such a surgery? Right, the answer will be D, ureter, at the greatest risk. You know what, that's a classical question from the UCMLE. You know what the UCMLE is, right? For those you guys who plan to go to the US and pass the step 1 exam and step 2 exam, that is the one which always in the exams, not this specific one, but questions about the relationship between the uterus and uterine artery, ureter, hysterectomy. Why? Because despite the fact that we are talking this from the year 1 to all medical students, those complications are still there. Pretty common, very difficult to treat. Okay? So please remember this. And speaking about the blood supply. So we have 2 kidneys, right? This one will be what? Left, a little bit above than the right kidney. Yesterday, TBL session, you mentioned why it is, right? Why is it? Because the liver is on the right. Now, in between those two kidneys, we have two major blood vessels. We have on the left side, what it is? Aorta, abdominal aorta. On the right side, we have inferior vena cava, AVC. So we have two renal arteries, and we have two renal veins to join them. What about ureter, right? So that is a ureter, which is sitting most posterior in the structures of the renal pelvis, and it runs always down, so it will help you to put it in the anatomical position, like separate specimen of the kidney. Ureter is supposed to go down, not the up. So how ureter will get the blood supply? And the answer is, it has plenty of arteries, because it's a very long tube, right? So at the beginning, the renal arteries will give like descending branch to the beginning of the ureter. After that, that is the gonadal arteries to supply testes and ovaries. They also provide some branches along the way to the ureter. After that, from the abdominal aorta itself, we have tiny, teeny visceral branches to the ureter. And finally, we have the vesical arteries to supply the bladder. They will provide us with the blood supply of the lower portion of the ureter as well. Are we good? Yeah.
What do you mean, vesical arteries?
Vesical arteries, the arteries to supply the urinary bladder. And we will talk about them in the few slides. Veins, don't worry about veins, they are run with the arteries, they have the same names. Okay, next one, the renal colic. You do remember we talked about the renal colic as a complication if you ligate the ureter during the hysterectomy, right? But that's not the most common reason of the renal colic. The most common reason of the renal colic is the blockage of the ureter with the renal stone. What the renal stones are? Where they came from? Correct. The renal stones, they are coming from the concentrated urine. They are crystals which are growing in the kidney, specifically in the pelvis of the kidney, or calyx minor or calyx major. If something has happened here, like for example, if the like inflammation and bacteria are there, they can be the center of the crystallization, and the renal stones or kidney stones will growing up. If they're small enough, that's good. They can travel with the urine. They can travel with the urine flow through the ureter. They can get into the bladder, and they can even travel from the bladder through the urethra out. And that's the best situation. The most of the stones, they are small enough, they leave the urinary system without any problem. The problem begins when the renal stones will be big enough to block the ureter. Okay? And blockage of the ureter prevents urine flow from the kidney to the bladder. And urine will be building up in the renal pelvis and causing the pain. How do we call this pain? Renal colic pain, excruciating pain. This renal colic typically is associated with the nausea and vomiting. It's not because something wrong with the stomach or esophagus. It happened because of the pain is so severe, unbearable pain. One of the most severe pains in our body. Also, the pain is typically associated with the hematuria. Hema means hemoglobin, the pigment, the red blood cells pigment, and urea, or urea, means urine. So we have the hemoglobin in the urine, we have the red blood cells, we have the pigment. Hematuria, is it normal or abnormal? Abnormal all the time. If the patient has hematuria, something wrong with the kidneys. It could be potentially renal stones as well. Now, the pain has a specific irradiation. We'll talk about this from loin to groin. And the real question is, those kidneys, the renal stones, sorry, not kidneys, the renal stones, the kidney stones, can they lock in the ureter any place? The answer is yes. But more likely, it blocks the ureter in the three specific locations. Why? Because that's the most narrow places. Most narrow places we call constrictions. So How many constrictions do we have in the ureters? Three. Why they are clinically important? Most likely place of the obstruction of the ureter by the renal stones or kidney stones. Now, where are the locations of those constrictions? That's probably the most important what you should pick up from these lectures. So the first one is sitting at the very beginning of the ureter. Ureter starts from what? From the renal pelvis. So renal pelvis will continue down with the ureter, right? So pelvico-ureteric junction, beginning of the ureter. Are we clear? So the first constriction, how do we call it? Pelvico-ureteric junction. Now the second constriction is at the pelvic brim. Pelvic brim, that is a place where the ureter from the abdominal portion will go down inside of the pelvic cavity, and here we have the bifurcation of which artery? Right, number 8, that's a common iliac artery, number 7, that is a ureter. Why artery actually make the constriction of the ureter? No.
Because of the blood, like the artery is pushing on.
Exactly, because of the blood pressure. We have the huge blood pressure in the major artery, that's one of the major arteries of the body. You cannot press it. The blood pressure is so huge, right? So, it presses the ureter instead. Okay, so the pelvic brim, level of the sacroiliac joint, the bifurcation of the common iliac artery, and the third constriction is inside of the wall of the bladder. So once the ureter will go through the wall of the bladder, it also has a constriction there because of the muscle of the bladder. We will talk about the muscles of the bladder. We call this the detrusor muscle. Very good. So again, one more time, 3 constrictions. The first one we call pelvico-ureteric junction. The second one is a pelvic brim. The third one, wall of the uretary bladder, the intramural constriction. Now speaking about the pain, from loin to groin. What does it mean, loin? That is loin. Loin, that's another way to say the lumbar area. Okay? That's where the kidney are located. So the pain starts from the kidney and will radiate down to the groin, where the groin is, where our external genital organs are, right? So from loin to groin, the pain will irradiate. It's a referred pain because we are talking about the specific level of the dorsal root ganglia, like L1, L2, and which nerves are associated with genitofemoral nerve, right? That's the one which will irradiate pain from loin to groin specifically. Are we good? Right, so that's a classical representation. And this part, a little bit radiology. So what you can see over here, how do we call this image? That is X-ray, but not the regular X-ray, because we can see the blood vessels. Can we see on the normal, on the regular X-ray blood vessels? No, we don't. But if we want to, what we need to do? Inject the dye, the contrast. If we will inject the dye in the arterial stream, we will visualize arteries, and we call this arteriogram. If we will inject the same dye but in the venous system, we will visualize veins, and we call this venogram. Okay, are we good? Collectively we call this angiogram, because angio, that's another way to say blood vessels. So what we can see in this image, we can see the renal artery and ramification of the renal artery into the 5 branches. We call them segmental branches. How many segments in the kidney do we have? 5. Now once we're talking about the segments of any organs, like segments of the lungs, you already know them. Segments of the kidney, you will learn segments of the liver and other organs as well. Why do we need to know this?
Because of the skin.
Because of the surgery will be the correct answer. You know, sometimes we need to remove, let me finish. We need to remove the organ. Like for example, something wrong with the kidney, like tumor in the kidney, right? And we call this surgery nephrectomy, because nephron, that is the Greek name of the kidney. Nephrectomy, removing of the kidney. Is it good for the patient? No way. Even we have two kidneys, the other one may be not functional. So if we want to save the organ, the functionality of the organ, we should, and the situation will allow this. So the tumor, for example, is benign or very small one, so we can preserve the rest of the kidney. Can we just simply cut whatever part of the organ we like?
No.
Why not? Because if we will cut something and remove, the rest should get the blood supply. If the rest of the organ will not get the blood supply, what happens? Ischemia, necrosis, and this part of the organ will die. So the point is, we can cut not whatever place we like, but we have to ligate first the specific artery which supply this part of the organ, which we call segment. And after that, we could remove this segment, and the rest of the organ will still get blood supply. Are we clear? I'm not talking only about the kidney, I'm talking about the general situation. Yes?
Doctor, won't ligating the artery increase the pressure?
Say it again?
Won't ligating the artery increase the pressure?
No, ligation of the artery will not increase the pressure in the system, because the pressure in the arterial system is very precisely regulated by the specific neural mechanisms, and you will learn this in the year 2. All right, so 5 segmental arteries, and should be able to recognize them. Again, you could not say left or right. Why? Because there is no labeling in this image. If the labeling will be there, you should be able to say yes.
So can we say from the 12th clip that this is the right?
You could say, but you don't forget about anatomical variation. The picture what you learn is just the average among all our human beings. Everybody is different. Right. Now the second is more important. Actually, we will talk about the pyelography. What the pyelography means? Pyelography means pelvis of the kidney. We will start with the pelvis of the kidney. We contrast basically the calyx minors, calyx majors, pelvis of the kidney, ureter coming down to the bladder. So we will see the urine flow and we can identify the problems. That's the pyelography. Now, pyelography could be done in the 2 possible ways. But again, it is X-ray. Can we see the urine on the X-ray? No, we don't. So what do we need? We need contrast, like iodine should be injected somewhere. We can inject this in the venous system, and the kidney will secrete urine, and we could get the picture like that. Are we clear? Right. But we can do the same thing, but in the opposite way. We can insert the catheter into the bladder, and we can inject contrast solution into the bladder instead of urine, and it will go under the pressure. It will go up through the ureters, all the way up, filling up the renal calyx, major, minor, and renal pelvis. But it will go back. That's why we call this, how do we call this? Retrograde pyelogram. Are we good? Send me email, please, okay? I will fix it. All right. So, again, the same structures we can recognize in the retrograde pyelogram. And we are coming to the urinary bladder. So, you see, you asked me what does it mean, the vesical artery. The Latin name of the urinary bladder is vesica urinaria. So, vesical arteries, it means arteries to supply the bladder. Make sense? Now, urinary bladder is sitting in the pelvis right behind of the pubic symphysis, so the most anterior location. Now, and that's adult. Once the bladder is empty, it is right behind of the pubic symphysis. But once the bladder is filling out, the full bladder will actually elevate and will be above of the pubic symphysis. That's an important point. We will talk later about cystesis, right? So parasynthesis, once we put the needle, so keep in mind that's important relationship, what you need to know. Now that's another view, that is a superior view, that is a cross-section of the body, superior view, and that is a male body. How do I know that is a male?
Bladder,
Right, you're all correct. So basically that is the rectum, colon sigmoid, upper rectum over here. That is the bladder. In between we don't have uterus, but we do have that is a vas deferens and seminal vesicles. Are we good? So the supra-posterior view over here. Now 2 points on this slide. Can you see that the anterior portion of the bladder becomes more narrow and becomes the ligament in the anterior abdominal wall, which will run all the way up to the umbilicus. We call this median umbilical ligament. Why is that? The answer is, the answer will tell you Dr. Paul. Dr. Paul will have a lecture with you. Ask him, why do we have this ligament and what the urachus is? Urachus is a canal which embryologically communicate bladder with the structures outside of the embryonic body. Now that was a duct, but in adults it's completely obliterated. If it does not, the urine from the full bladder can go up to the umbilicus and drip from the umbilicus in adults. We call this urachal fistula. Again, that's a mostly embryologic conception, and I do believe Dr. Paul will talk in details about this. If I will ask you in anatomy, good enough if you remember that's a medial umbilical ligament, urachus, urachal fistula. The dribbling of the urine from the umbilicus when the bladder is full. The second point is also very important. That's a bladder, and we have a muscle in the wall of the bladder. How do we call this muscle? The trusor urine muscle. Now you will have histology with Dr. Rani, and she will talk you in details about the 4 layers in the bladder wall. The inner layer we call of the bladder we call mucous. The next layer we call submucous, and because of that we have a folds. The next layer will be muscular layer, and that's what we call the trusor urine muscle or the trusor muscle. And the outer layer we call adventitious or serous layer, peritoneal layer. Are we good? By the way, could you tell me this, the trusor urine muscle, is it skeletal muscle or smooth muscle? Smooth muscle.
Both actually.
Actually, only smooth. Only smooth. And since it is smooth, it is innervated by which nervous system? Autonomic nervous system, the one which you cannot control. Okay? Now, but you say, I could control, right? That's newborns which are peeing all the time. That's why we need pampers. But adults, they could control. But it is not the bladder we control. We control the external ureteral sphincter. That's the only voluntary muscle which we could control, and we can hold for a while, but not for the long time. So that's important to reach in time, right? To the restroom. Once you sit on the toilet, okay? What are you doing? You're relaxing. And once you're relaxing, you activated which nervous system? Parasympathetic. So we would say the trusor urine muscle, it's activated by parasympathetic. Once you're in stress, the trusor relax. It's not time to pee. Once you relax, parasympathetic prevail, and you can micturate. All right. Question for you guys. A stab wound, what does it mean, stab wound? With a knife penetrating the body. A stab wound immediately superior to the pubic symphysis through the anterior abdominal wall would most likely injure which internal organ? Bladder. Correct. No, that's wrong. Bladder is correct answer. Something wrong with this presentation. Anyway, ureter has nothing to do with that. Bladder is the correct answer. I'll fix that. It's a technical mistake. Right. Now about the anatomical relations of the fundus of the bladder and body of the bladder. Okay, we have two pictures. We have male and female, right? In the male body, what do we have behind of the body of the bladder? One more time. Seminal vesicles and vas deferens. In the female body, behind of the bladder, we have uterus, specifically cervix of the uterus, and that is vagina. So vagina and cervix of the uterus in the female body, in the male body, vas deferens, vas deferens and seminal vesicles. Are we good? So that's behind. What is underneath? Inferior, we have, what is it? Prostate gland in the male body. And in the female body, we have just the urogenital diaphragm. We do have the urogenital diaphragm in the male body, but it's underneath of the prostate. Are we good? Are we clear?
Yes.
Now, from this relationship, it's coming the clinical application, what we call cystocele. Cysto means what? Bladder, cyst, and cele means protrusion, herniation from the body. So bladder herniate, protrude from the body, from the female body. So the posterior wall of the bladder will protrude down and will be visible through the vagina. Okay, like the anterior wall of the vagina with the bladder will protrude out from the vagina. So question number one, why does it happen? So it happened because of the weakness of the major muscle of the pelvic floor, and the major muscle we call levator ani muscle. So it's literally elevate anus during the defecation. That's the strongest muscle of the pelvic floor. Now, second question is, what could cause the weakness of this muscle? And the answer is the multiple childbirths. Okay, so if too many kids or children, once they exit through the canal during the childbirth, they traumatize the canal, traumatize the muscle. Okay, so what happened? The weak wall, weak support for the bladder, and that's why the bladder can protrude through the vagina. Vagina wall is weak enough. Without the support from the levator, any muscle, it cannot hold. Yes?
What's the difference between this and prolapse?
Prolapse, it's another way to say cystocele.
The same meaning?
Yeah, prolapse meaning something going out. The cystocele, that's specifically about the bladder. Prolapse we mostly use for the uterus. Uterine prolapse or rectal prolapse. Okay, neck of the bladder. So what do we have in the neck of the bladder? That's where the urethra starts from. In the male body we have this gland. Which gland do we have? Prostate gland. In the female, what do we have?
The diaphragm.
Urogenital diaphragm. Very good. Now about the cystic trigone. Again, histology with Dr. Ani. 4 layers. That's the inner layer mucosa. After that we have submucosa, and because of that we have plenty of irregular cells, and because of that the bladder can expand once it fills enough with the urine. After that you can see the huge muscular layer. How do we call it? Muscular layer of the bladder, the trusor muscle, and after that we have the adventitia or peritoneum. Now you can see the plenty of folds. Why do we have folds again? Because submucose. Because submucose. One part of the bladder has no submucose, and because of that there are no folds. It's totally flat. What is the shape of this part? Trigone, right? So cystic trigone, triangle in shape. What do we have in the corners of this triangle? We have openings of the 2 ureters. Ureters, we call them ureteric orifices, left and right, and urine will constantly coming out from the kidneys, right? And the inferior opening will be the urethra. We call this internal urethral orifice, right? That's where urethra starts from. That is the female body. In the female body we have very short urethra. So the point is that is the cystic trigone, and you can ask me, so what? What is the point? You raise your hand, who wants to be histologist? Ha. Raise your hand who wants to be a physiologist. Okay, I will tell. Who would be anatomist over here? No way. So guys, the point is you're all enrolled in the MBBS program, so you plan to be physicians. Every part of the anatomy we are teaching you, it has the clinical significance. Unlike I was students 30 years ago, they taught us everything. So that's why I remember all those small tubicles and everything, which basically has no sense. The sense is, once we go in the clinic and we do cystoscopy. What the cystoscopy means? Can you see this device? We call it cystoscope. What we are doing with this device? We put it through the urethra inside of the bladder. That's why it is cystoscope. It's endoscopic device. And we have the optics over here to see what's going on inside of the bladder. Inside of the cystoscope, we also have, what else except of the fiber optics, we have light, and we have, typically we have few instruments, few tools what we will use. We have a cutter, we have typically the forceps to remove stones from the uretary orifices. So, but that's not my point. My point is, with the cystoscope we can do not just the diagnostics, but a lot of the useful surgeries inside of the bladder. But the real question is, okay, you are inside of the bladder, what would you see through the cystoscope? Through the cystoscope you will see huge amount of the irregular folds, and you don't know where you are. In order to recognize your location, what are you looking for? You are looking for the cystic trigone. Once you pick up the flat space, now you follow till the angle and you can find the ureteric orifice, what we are looking for. Are we good? So that's a key landmark for us, yes.
So cystic trigone is for both males and females, or only?
Of course, cystic trigone we have in the both, in the males and females. Because in the both genders we have identical ureters and we have the beginning of the urethra. It's just the length of the urethra is varied. But the bladder is totally the same. It has a different relationships anatomical. But as organ, it's absolutely identical.
Even the size?
Yeah, even the size. It has a significant anatomical variation. It's not about the gender, but more likely how big your body is. Okay, blood supply of the bladder. You asked me about the cystic arteries, right? So the vesicular arteries, vesica urinaria, another name to say bladder. So we have two vesical arteries. We have superior vesical artery, which is always branch of the umbilicus artery, and that could be equation during the exam. And we have the inferior vesical artery. Now, inferior vesical arteries, they are branches of the internal iliac arteries. But we call them inferior vesical artery in the male body. In the female body, the same artery we call vaginal artery. Why is that? Because in the male body we have vagina, and in the female body that's the artery to supply vagina and lower part of the bladder. In the male body it just supply the lower portion of the bladder. Yes?
So, can you repeat the superior one? Something about the exam? The last one?
I didn't say anything about exam. So you have to know for the exam where those artery originates from. Okay? So superior vesical artery is coming from the umbilical artery, inferior is coming from the internal iliac. Are we good?
Do you have an umbilical artery, or?
We all have umbilical arteries, we still have it at the beginning. That's a problem, GI block is coming late. Right, and the last slide, suprapubic aspiration. So guys, sometimes urethra, especially in the male body, cannot pass the urine. Like for example, the most common example is the problem with the prostate gland. In the male body, urethra is supposed to go through the prostate in order to relieve the urine. And if the prostate becomes big, like hyperplasia of the prostate gland, could you please stop talking? Or when the hyperplasia of the prostate gland happened, the urine cannot go through. But it still will fill up the bladder constantly, and the bladder becomes huge and painful, and we have to relieve the patient's bladder. How could we do it? We cannot do this until the surgery done for the prostate gland. So temporarily, to relieve the patient's bladder, we can do the paracentesis. You talked already about the paracentesis for the pericardium, for the pleural cavity, right? We can do the paracentesis for the bladder as well. So basically, paracentesis means a needle which will pass through and relieve something, fluid. So we can place this needle right above in the midline, right above of the pubic symphysis. That will be the exact location to know. So we palpate the upper point of the pubic symphysis. We place the needle over there, and we put the needle through the anterior abdominal wall to get into the bladder. This picture is wrong because it looks like the needle crossed the intestine, which never happened. Why? Because intestine will be pushed above of the bladder. Once the bladder is full, it pushes everything about, including peritoneum, so there is no risk of the infection. Are we clear? So you have to know where to place the needle, and also you know before the surgery, instead of the needle, the catheter could be left over. What is shown over here, that is a catheter. Why do I know this? Because of this balloon. Can you see this? That is an air-inflamed balloon, what we have at the end of the catheter. Once the catheter is inside of the bladder, urine will go out, and in order to leave it there, we inflame the balloon at the end of the catheter, so it will stay until it is needed. Okay, are we good? Any questions? Okay, thank you guys, and enjoy this painting from Dr. Elena, and I'll see you guys tomorrow.